Hi, and welcome to the May 30th, 2012 Plastic Surgery Journal Club. I'm Dr. Damien Marucci and this is Dr. Queenie Chan. We're here at St Vincent's Hospital in Sydney. Queenie's one of the plastic surgery registrars working at St Vincent's and at Bankstown Hospital. As usual, we did 4 papers. You can see the names of the papers coming off on your screen as we discuss them. So, Queenie, what was the first paper?
The first paper was looking at the Brava external breast expander and whether it is a safe and effective way of creating bigger augmentation volumes. This study was done across 6-year period on 81 patients, and it's a prospective multi-centre trial. They looked at MRI results pre and post-op and measured augmentation volumes and the percentage of graft take.
Yeah, so essentially what they were doing were women who were capable of tolerating the Brava device were wearing the device for 10 hours a day for 4 weeks. Then just before their augmentation with autologous structural fat grafting, they were wearing the device for between, I think, 36 hours straight.
Correct.
Then they underwent a large volume fat grafting, and then they went back into the Brava for a little bit longer. And this looked at the long-term results with mammography. And the results were discussed in our journal club this evening, and they were very impressive results. What did people think about the paper?
It was generally a very good paper. It was well structured with statistically significant results, but clearly compliance was a huge problem in this paper, and they didn't include the non-compliant women who unfortunately had issues with wearing this Brava expander. And also it was interesting to note that the women that did have calcifications on MRIs, interestingly they didn't have injections of these fat grafts into the breast parenchyma, so it's interesting to note that they did actually have calcifications in the breast tissue itself.
Yeah, that was one of the things that people raised in the discussion. Obviously the idea of fat grafting to the breast is not to actually put the fat graft into the breast parenchyma and rather put it underneath or superficial to it. But as we discussed, can be very difficult in order to get the plane just right, and so there is a risk of putting fat into the breast parenchyma, which may have implications in terms of subsequent mammographic assessment of these patients. Other things that people thought was it was a good paper because it's a multi-centre paper. Obviously the follow-up was long-term and rigorous with both MRI and mammography. There was no mention made of patient satisfaction or post-operative pain, just the assurance that pain was not an issue. And there was also noted that the lead author also has a financial interest both in the Brava device itself and also the LipoGrafter kit, which was used for the fat grafting. All right, I think it's about it for that paper.
I think so too.
Okay, good. The second paper we looked at was also on the topic of fat grafting to the breast for cosmetic breast augmentation. This paper was called Mammographic Changes After Fat Transfer to the Breast Compared with Changes After Breast Reduction, a Blinded Study. This paper compared women who had had fat grafting done for augmentation in Japan and their post-op mammograms with the post-op mammograms of women in the United States who had undergone breast reduction, and basically commented that that there was no, or the overall implication was that there was no increased risk in terms of mammographic assessment just due to fat grafting alone when compared with patients who had undergone a breast reduction. So what did people think about this paper?
People thought that sort of caution should be made when making the statement that fat grafting is safe. Rather, we should be saying that fat grafting, when compared to breast reduction surgery, for example, it does not make breast cancer detection any more challenging. The other thing that people commented on was that perhaps a different control group should have been used. It's quite different to be comparing fat grafting augmentation to a breast reduction surgery in 2 very different groups of women, not just ethnic background, but BMIs and the type of surgery that's performed. So it would have been good to see a better control up against this cohort of women that they looked at.
There was an excellent discussion paper which was published in the same issue of PRS, which is actually the current PRS volume 129, issue 5, by Scott Spear, where basically Scott Spear made all of these points, including the point that there was a very high incidence of calcification requiring biopsy. In fact, a higher incidence of calcification requiring biopsy in the lipografted group as opposed to the breast reduction group, although this did not reach statistical significance. Overall, the paper found that the incidence of lesions requiring biopsy, not specifically calcification, but any sort of mammographic lesion, was higher in the breast reduction group. But specifically looking at calcification, which, as Curry discussed in the Brava paper, is something that can occur after fat graft necrosis. It's sort of one of the concerns that people have about doing structural fat grafting in the normal breast. Anything else about that paper?
I think you've just about covered it.
I think that's about it. All right. The last two papers we had were on completely different topics. The first one was clinical outcomes. This is by Barman Gurian in Cleveland, Ohio, published in PRS earlier this year. Clinical outcomes following supraorbital foraminotomy for treatment of frontal migraine headache. So in a nutshell, it's been well known for the past decade or so that Botox is an effective treatment for many patients who have different trigger points for their migraine, whether it's frontal or occipital. Dr. Gyron has then taken the next step and looked at actual corrugator resection or resection of the muscles in the glabella area as a means of giving you almost like a permanent Botox effect in order to decrease the incidence and severity of migraine. Working from there, he, in some patients, in addition to performing a glabellar muscle resection, also performed a supraorbital foraminotomy. And the result of this paper, basically speaking, was that when he did the foraminotomy, in addition to the muscle resection, the patients actually had a further decrease or a better result in terms of the relief they got from their frontal migraine headaches. What do people think about this paper?
Well, first of all, not many plastic surgeons in Sydney, I believe, are familiar with the techniques of treating or surgically treating frontal migraine headaches. So it's definitely a very interesting paper. But I guess I think people would have liked to see more is the results, particularly the outcomes in relation to return to work and a quality of life. And perhaps looking at analgesia requirements and days off work as a result of these migraine improvement or worsening, as it may be.
To be fair though, although that was a comment that was made, I actually thought Dr. Gyron's paper has actually gone into quite a lot of detail in the kind of measures they were looking at. Like they're looking at the migraine headache index score, severity of pain score, headache frequency. I thought they were all valid measures. I mean, some people were just saying, I would have liked to have seen this, I would have liked to have seen that. I mean, a paper can't add everything, but I think this one, I thought it was a pretty robust
study.
Yeah. So it was retrospective, but Dr. Gyron appears to be taking excellent notes, and I think everyone agreed it was quite an interesting paper. And as we discussed, this is a surgical technique which is really pioneered by Dr. Gyron, and there isn't anyone in Sydney that we know of who is doing this technique, but this may be a service we may be able to offer our neurological colleagues in order to help out patients who have intractable migraines who are not getting relief from other means. All right, anything else about that one?
No, I think
okay. The last one was a particularly interesting paper. The possibility and potential feasibility of putting an extra functioning free muscle transplant onto a normal limb, experimental rat study. So this paper is out of Taiwan, published in PRS last year, where what they did, they had genetically identical rats. They took the biceps muscle from one rat and transferred it onto the bicep of another rat as a free functioning muscle transfer. And then how many months down the track?
They don't actually specify the time frame that we're looking at.
All right. Well, down the track, then looked at a number of measurements, arm circumference, the elbow flexion force, an electrophysiological test, and a bicep muscle contraction force measurement on these rats that had an extra muscle transplanted on top of their existing biceps muscle, and basically found that this free functioning muscle transfer actually translated into both a cosmetic but also functional improvement over a control limb. So what do people think about this study?
It's obviously a very experimental study, and most people thought there's very limited application in human subjects.
At the moment.
It's interesting that the authors mentioned a potential use in sportsmen or heavy labourers who may need that extra bit of performance enhancement, but I think only time will tell as to where this will take us, this particular new technique that they've described.
Yeah. And they also measure the cosmetic enhancement as well. So, for example, people wanting, men wanting chest enhancement surgery, some men go for small pectoralis implants. Could this be an option, actually having a functional muscle transfer? Obviously, we use donor sites all the time, but it's hard to think of too many people who'd put their hand up to move a latissimus dorsi around or even a gracilis muscle around for a reason like this. But certainly this is a very interesting, groundbreaking study.
Indeed.
Whether it goes anywhere in terms of application to clinical human practice, it's hard to see, but interesting all the same.
Indeed.
All right, well, Queenie did an amazing job preparing tonight's Journal Club. And to those of you who are there, thank you very much for coming. And to those of you who are watching now, thank you very much for listening. Okay, thank you very much. Thank you, Queenie.
Thank you, Damien.
Okay, thanks.